Let me begin our event this morning, our Voices in Health event. This is Peter Berman, the director of the School of Population and Public Health at the University of British Columbia in Vancouver. And I want to thank you all for coming to this event. A bit of an unusual time for us in the morning, but we are taking advantage of the current situation of physical distancing to allow us to invite a speaker from abroad who didn't have to spend 2 days going back and forth to visit us. So this is maybe a harbinger for the future of our ability to share more broadly internationally. Let me begin, as we do, by acknowledging that even though we meet today virtually, we are all privileged to be able to work on the traditional and unceded territories of a number of Indigenous peoples here in British Columbia. And as always, we're very grateful for the opportunity to gather on these beautiful lands. Our Voices in Health event today is entitled Climate Change and Health, Impacts and Responses. And I want to just note that we are continuing our effort to alternate between more global topics and more local topics, however you might interpret that, since certainly climate change and health is both. And so this is a good example of overlapping interest. And let me now introduce Dr. Mathilde van den Bosch, who's going to be our moderator for the session today. Mathilde, over to you.
Thank you very much, Peter. I would also like to say welcome and many thanks for attending this Voices in Health event today. Right, my name is Mathilde van den Bosch, and I'm an assistant professor here at UBC with a joint appointment at the School of Population and Public Health and the Department of Forest and Conservation Sciences. As Dr. Berman said, I will be moderating this event today, and the schedule will be as follows. So we will soon start with our keynote, who will talk for approximately 40 minutes. And then between 20 past 10 and 10:35, our expert panel will share their reflections on the talk. And after this, we'll follow 20 minutes for questions and answers from the audience. So just a note that we will be holding off questions until after the panel discussion. And now it is my great pleasure to introduce our distinguished keynote speaker for today, Professor Rainer Sauerborn. Dr. Sauerborn is a trained physician and has conducted research at Harvard University, among other institutions. For the past decades, Dr. Sauerborn has worked on the nexus of climate change and health, particularly focusing on populations of the Global South. From 1997 to 2016, Dr. Sauerborn served as the head of the Institute of Global Health at the Heidelberg University Hospital in Germany. He is also a guest professor for global health and climate change at Umeå University in Sweden. Dr. Sauerborn has worked for several years in Burkina Faso, and much of his work has focused on improving the quality of and access to healthcare in low-income countries, the so-called majority world. Dr. Sauerborn is also a member of the Intergovernmental Panel on Climate Change, the IPCC, and his current focus is on a new 11-partner consortium research project on climate change and health in sub-Saharan Africa. So without further ado, I would like to bring a warm welcome to Professor Rainer Sauerborn, and please, over to your presentation.
Yes. Hello, everybody. Sorry, I'm getting ahead of myself here. So welcome, everybody, and thanks so much, Peter, for inviting me. You say it's a blessing that I'm not around. Which has some advantages, but I definitely want to visit Vancouver, particularly that he put on his background screen of blossoming flowers before a skyline of mountains, snow-covered and so forth. So it's a beautiful place, and I know what I'm missing. It is also clear that I'm socially distancing. That's about, 20,000 kilometers. Nothing can happen in terms of COVID here. And I want to now, without much ado, start my presentation. As Peter said, climate change is the perfect storm for global health. There's nothing more global than climate change. And this is a huge topic, and I break it down in 8 components, as you will see. I wanted to give you an overview of all the 8 components, so I can't have the depth that I would wish on all of them, but I hope this is not the last thing. We have also MOOCs, which you can, massive open online courses, develop them, which is available, or the link is available at the website of the Voices in Health or for Health. So you can look up further stuff. Also the wonderful report, this is an old-fashioned way of showing something, the Canada's Changing Climate Report. I first thought the report was changing, but it's obviously the climate that's changing. Good. Why do we do this? There's a social motivation here because we all know that cumulative emissions are historically largely generated by the global north, and the health impact, whether it's mortality or cases of this and that, are mainly borne by the south, which is one of the many inequities in public health, but probably one that gets more and more pronounced. And unfortunately, our health research output on that area, research output in climate change and health, is miserable. Particularly, and here we copy the inequities as scientists, particularly where the problems are greatest and the vulnerability is greatest and the possibilities to do something about this is least. So just where research should be, it's not happening as much as we would like to. So here you see in one of the COP23 in Bonn, but this is looks like same everywhere. The climate conference is huge, crowds, mixture of experts who meet in one side and then NGOs and scientists and whoever on the other side. And I put health in the middle because I think that health should not be left to the doctors, as there's a famous saying, first of all. And second, health has a key role to play in climate policy. I know that Peter, and I learned it from him, that policy is very important if you want to move the needle in any aspect. It's good to have focused intervention, but there have to be global policies. It's nowhere more true than in climate change. So I put health in the middle of a conference room of climate policy debate. And I hope I can convince you that this is not only a gimmick, but that there's a lot of reason for it. So we have 4 positive messages that emanate from health. And positive messages are rare in the discourse of climate change, or in climate change in general. And we should honk our horn where we have positive messages to counter the doom and gloom message, which is prevailing, unfortunately. And we have also 4, well, you can call it dangers or attention marks, exclamation marks. I mean, please be careful. So let's start with the 4 green ones, the positive ones. Health is the motivator. Why do we do anything about climate change? Because we want to take care of our health, the health of our kids. I have 4 of them, so that's my main motivation. And our grandkids. This is about our life. It's not a physical event that's somewhere happening, but it's affecting our life. So health protection is the main motive of every citizen, everywhere in all cultures. Then there are huge benefits if we do the right things, either behaving properly in climate-friendly ways or climate-friendly policies. We generate enormous health benefits, which, if monetarized, counterbalance the efforts, the financial efforts of mitigation policies. Unfortunately, that has never been really put into the spreadsheets, but it should. Health systems, as we all know, are there to protect the population against all sorts of things. For the moment, it's COVID. It can be any health problem, and climate change is one new risk factor, queuing up and interfering with the known health risk factors that you all study in your school, from smoking to physical activity and so forth. And then there is health science, although I could also put this in the red box because it's not yet there. And this is why I want to motivate you, as some of you young scientists, particularly you looking for the topics for theses or so, try to get your teeth into this very challenging field of climate science and health as a person, as a scientist. Then there are warnings. Beyond 1.5 degrees, there is a lot of damage. It's not damage-free below, but there's clearly a threshold that is passed, as you've seen from the latest IPCC 1.5 report. And that should be a message to all these guys in the meeting room there. If you don't get your act together, we will see 1, 2, 3, 4. Do you and your constituents and your countries want this? You will be held responsible for these effects. And we just see how COVID ravages societies. 200 countries are affected. The same will be true in climate change, but at a much greater scale and irreversibly. That's the big difference between anything we've seen and climate change. Climate change does not go away, as will COVID one day. Or we can manage living with COVID. Okay. There are limits of adaptation, should be our message to these guys in the room. You cannot look to us white coats to fix the problem. We may be able to fix it in COVID by developing a vaccine, but we cannot, beyond 1.5 degree, manage or cure or immunize against or whatever fantasies you have. We cannot. You are responsible and we cannot help you. The health sector is also a big emitter. I will just touch on this. We can't say, oh, we are doing good, we are saving lives and so forth, so what the heck with the CO2? There are clear statistics that show that some countries do the same quality of healthcare, generating the even better indicators with much less money, as we all know, but also much less greenhouse gas emissions. So we should touch our own nose, as we say in German, and not only look at others to sort things out. And then there is a huge health physiology-mediated economic loss for all people working outside. In the open, they're exposed to the temperatures, and there are physiological laws that force you to rest. And this will wreak havoc, particularly in hot countries, which will get even hotter. Okay, this is a little bit on climate science. Peter told me that while there are a few experts among you, and all of you have some grounding, but let me just rehearse some of the key concepts. So here is the kind of equation. You get the population. So the numbers matter. It's a very contentious issue. Family planning is one of our tools, voluntary, I want to emphasize. That's one way of getting these down, but not the first, of course. GDP per person, we cannot stop growing, but we can generate the same GDP, same quality with less energy, and we particularly, that's where we start, can decarbonize energy, then energy is no longer a problem. So that's just a rehearsal from how these anthropogenic emissions arise. There's not only the emission, there's also land use, and 25% come from agriculture, forestry. It's very often forgotten. And these two lead to changes in the upper atmosphere, climate change. We'll talk more about this. That leads to some diseases, and the diseases can progress if not stopped and lead to death, God forbid. And we have adaptation policy. Adaptation in climate jargon is just stopping the impact to arise and protect people given exposure. So we don't change anything about this cascade, but we try to protect populations. But we should also, and that is maybe new to many of you, we should also get involved, get our hands in and our arguments and our evidence in the mitigation debate. That's the brown part. Particularly that we generate health co-benefits. Not we, but by doing climate policy, we should tell policymakers that you generate positive health that accrues to the person who does the right thing. So if I let my car sitting around somewhere in the garage and I move and jog, and only I get healthier. All the other public health effects are for everybody. But here, this is for me, and this is particularly motivating. Okay. Now, let me just run through these key terms quickly. Impacts, obviously, any effect of climate change on health. Adaptation is protecting potential patients or people from. Mitigation is reducing the emissions or increasing the sinks, forests, for example. That is something that, that got out of line, that Tony McMichael called adaptation is managing the unavoidable and mitigation is avoiding the unmanageable. Nice pun. Then the core benefits is also called the double dividend. It's that while you mitigate, while you do good climate behavior or good climate policies, you become healthier, or your people or your populations become healthier. Then there is the RCP. You need to know that because all the slides, they always show RCPs. These are basically the climate models. They come in four scenarios. One, the lowest one is 2.6. It's measured in watts per square meter. That means the increase in the energy content of the atmosphere. And the worst, the business as usual, no climate policy, we leave everything run its course, it's 8.5. Just remember 8, the higher it is, the worse is the emission situation. All this is, of course, based on social pathways, so assumptions on social, economic, and demographic pathways. So what does the world look like in terms of inhabitants? Attribution is the art of defining what proportion of climate change is attributable to human activity. That is basically done deal. But now it is the proportion, in our case, of health damage that can be attributed to climate change. You can imagine that there is no new climate disease that's only influenced by climate change. And all these 100 plus climate sensitive diseases are also object to other influences, social, other ecological, you name it, genetic, nutritional. So it's the new kid on the block, but a kid that affects everybody in all corners of the world. And so it's a unique situation. Weather is the current state of the atmosphere, and climate is the average state over 10 years. So you cannot say the weather forecast is so bad beyond 2 weeks. How can you do a climate projection? This is just two completely different things and different approaches. But the variables are the same, like rainfall, temperature. It's just that one is an average over a large number of years. And the weather is today, now at this time in Vancouver. And climate change is then a gradual change of this. And here we talk about 30 years or so. So the problem arises, how do you do research if something changes so slowly? And we have changes in temperature, rain, wind, sea level, and the short-lived climate pollutants, also something you might wish to retain, SLCP. These are those pollutants that are generated particularly by burning fossil fuel, and which are giving you, for example, if it's black carbon, giving you breathing problems and cardiovascular problems. They are air pollution items, but generated through the same source, namely burning fossil fuel, as the very well-known one. Here is one that looks familiar to you maybe, but if you look at the x-axis here, you see it's until 2300. Usually these projections stop here, and you see why, because it gets extremely bad with the business as usual. This is this one, RCP 8.5. It goes through the roof. It doesn't even stabilize. It's at a high level anymore. The other ones, and there's only one that gives us so that's the no policy. That's the famous 4 degree by the end of the century. but 12 degrees, or you have it by 2300. And then the current pledges, that means that what after Paris every country promised to do, only reduces the temperature by 1 degree. We know that Paris had 2 degrees as the utmost, and 1.5 is actually the target. So it's our choice. It's human-made, and the climate policy is also human-made. There's no other way to get a handle on this. It's something that many people overlook. It's not only gradual change, as you would think here, so an average moving inexorably from one side to the other, temperatures, humidity, and so forth. But it's also that these variables get more extreme. So here is, before I got into this, and many of you maybe think it's like a Gaussian distribution of, let's say, temperature, and that moves to the hotter. And then you have the pink and the red areas that are now much bigger than they were before. Here there was only this little part, now you have this big part, and here the very hot weather. But unfortunately, it's not all that happens, but the tails get fatter. So this is the effect of the fattening of the tails, and this is the effect of both. And so you see what you thought it would be only here becomes very much more, and particularly the extremes here are getting much fatter than just by the moving of the same curve along more hotter temperatures. Here's a slide from Canada. That is an explanation of this. It shows what in 1986 was a 1 in 50 hot year is now a 1 in 1.5 year. So it becomes almost normal. So there's a hot summer, a hot year here. We thought it was very exceptional. Now we have to live with it. So that's one way of explaining why we think that extremes will become more common. You should also know that climate change, although global, is by no means globally uniformly affecting people. I'm not talking about health. I'm just talking about temperature, for example. And unintuitively, the more you go to colder areas, to the north or to the south, the larger the number of absolute degrees of warming. So what is very cold will get relatively larger warming, and what is already hot, like here, it's this is where Burkina Faso is, for example. It will increase maybe by 2 or 3 degrees, but here, where the ice is, 8 degrees, and Canada is in the middle. So you are sitting in a country which gets probably in the worst scenario, where 4 degrees warming is the average, you will probably get 6 or 7. So you are on the, if you like, on the wrong end of the warming, although you're relatively cold. I hope this is understood. Same is true for rainfall. So rainfall is not so simple as here. We say the more you get to the poles, the more you get to land, over land, and the more you get to the Himalayas, to the heights, to the altitudes, the more absolute numbers of degrees. Here it is very, very scattered, and it takes too long to explain that. Just to let you know that there's no 1 degree or 1 rainfall change that fits everybody. Here's again something from Canada. Here you have the different climate. Here's the best climate scenario. If we do really everything right, you see it gets not much warmer. This is until 2050, and this is until 2100. Here you see, my God, you're in the 9 degrees here if you're in this area of Canada, and where you are, you may be lucky to get 7 degrees, right? So make sure that you don't think that global means same everywhere, but the phenomenon is global. The same is from oops, what happened to them? The same is from Africa. Our own research, we looked at different temporal variation, different years in one village. There was a weather station, installed a weather station, and you see extremely different patterns of rainfall. Don't want to get into this. This is very bad for agriculture, because you have people start sowing then there's a stop, and then it starts again, and then there's one torrential rainfall. But the cumulative rainfall is okay. It's roughly the same as here. So the temporal patterns of all climate variables are disrupted, which means very bad news for agriculture, for forestry. Spatial variation of weather is also increased. Here you see these 5 weather stations, and you see the number of rainy days varies enormously. This area where these 5 are located is 2,500 square kilometers. That's 50 by 50 kilometers. That's not very big, but you have large variations in between. Okay, so now let's move to health is a motivator. And here is a slide that my doctoral student from Burkina, Raisa Sauerborn, presented at the World Health Summit in Berlin. She said, these are my parents. Here you see, by the way, the RCPs and the temperatures, and it goes to 2,300, right? Same thing. Okay, here's my parents. They have contributed to getting us into the mess. Here's myself. That is herself. And I am probably suffering from it. My lifespan is there. Then my children, I don't know, well, it takes other children, maybe someone from the very north, Inuit, or here. These are children who are going to live through this. What we do, they have to suffer from. So what is more motivating than protecting these kids? Could be your grandchildren, your great-grandchildren. So that argument is so compelling and is so commensurate with the persistence of CO2 in the atmosphere. This is a problem that doesn't go away. I can stop COVID in my generation, but I cannot stop. On the contrary, I can do it. I can let it happen, and then everybody after me has to live with consequence or suffer the consequence. And this is also from Canada. They modeled here, what if you stopped by model? In models, you can do this. Let's assume here you go on and on and on until you have a global mean temperature. No, not a global, Canadian mean temperature of 16 degrees, which is pretty high, night and day. And then we take the climate change away out of the models. Whoa, it stays. And look at the x-axis. It goes to 3,000. It doesn't change. So what we do is there to stay. That is the message. Mm-hmm. Well, so health as a justification, that's also good news. Health is very often invoked by policymakers as a reason to enact legislation. This is a study we did for the climate conference in Paris, where we looked at EU legislations, and these are all legislations, and these are the legislations that in their preamble invoked health. So the reason why we are doing this and that regulation is because we want to protect the populations of Europe from climate change. So it's not just that I say this, it's really borne out by facts. We even looked in the text of the legal documents, and it's clearly most of them have behind them a clear health rationale, although they are not limited to health as an outcome. So, and now comes, since you've went through this, comes a little video clip, which is from a MOOC, which a team at Sauerborn University in Paris and myself prepared for the delegations of the Paris conference. Let's see whether this works. It's 2.5 minutes. Oh, 2 minutes maybe. It's a teaser. It's just explaining what is happening in this MOOC and what you will see. The MOOC consists of 4 pages, but listen.
I'm Rainer Sauerborn. I'm one of 4 health scientists from the IPCC team who put this together for you. It is a brief for policymakers of national, local, or international levels. The argument we want to put forward to you is that health is more than just one of many other sectors like agriculture, forestry, and so forth. But health is useful to be an argument, a leverage in otherwise conflictual and interest-guided debates. And we do this in 4 presentations, according to 4 key arguments, which I will just quickly go through. The first argument, everybody cares about health. Health is a key motivator, both for our personal individual behavior. After all, we all have to change our lifestyles to be more climate friendly, but also negotiators. Everybody cares about health and their constituency. So it is an argument that drives change, that generates energy to do something about climate change. The second argument is, what is good for the climate is good for health. That's true in most cases. Let me give you one example. Indoor air pollution kills 4 million people a year, mostly women and children. Outdoor air pollution kills 3 million. This is huge, a huge human loss to one environmental problem. If we decarbonize our energy system, much of this will go away. So by doing something for the climate, we also do something for our health. And that is a very positive argument to follow, rather than the doom and gloom scenarios that sometimes are put forward. So we make our planet not only a climate-friendly planet, but also a healthy planet. The third argument is more of a warning nature. There are limits to adaptation. And with limits, I mean health limits, from our physiology, from the way our body works. This is true certainly for our limits of adapting to a warmer world, to higher temperatures, but it's also true for our coping with other diseases that will be increased due to climate change. The fourth argument is, if you like, a health-based economic argument. We showed that if temperature rises, then there's a physiological law that your work output, your work effort decreases. And this is very bad for tropical and subtropical countries, which are emerging as
Okay. Do you hear me again? I hope. So I continue. So these were the 4 main points of our 8, which we selected for presentation to the COP conference in Paris. Now, I mentioned the health co-benefits. Let me quickly go through them. And you get this presentation, of course, on the website. So if you want to look it up. The health-damaging short-lived climate pollutants, you heard this in the video, promote clean cooking fuels and stoves. If you do this, you get a lot of health benefits. It's amazing. Decarbonize energy generation also in our countries. Germany is still doing a lot of coal. I know that Canada is also not very clean on this aspect of fossil fuels. So we have to decarbonize it. Decarbonize transport and get physical activity. Climate-friendly household consumption. I will get a little bit into this later. Insulate our homes and build a climate-friendly environment with green gardens, vertical gardens, you name it. And eat less red meat. The last thing I mentioned already, provide access to reproductive voluntary health services. It's not for now, it's maybe in 25 years that these people that are born today will want to have a life maybe that we have, and that will add to this problem. So we have to not persuade people, but we have to give people the ways to do their chosen family size, which is 0.8 children fewer than they have. So people are beyond what the family size that they really want. You can put this into money. Here's a study from the NHS. 1 billion pounds from savings for the NHS, from diabetes care, dementia, and so forth. So it is huge, and it can be monetized. It should be in the spreadsheets of these negotiated teams, but it isn't. And our own behavior, we should not always point to industry and to big fossil energy generation. 60% of emissions in your country, mine, and other OECD countries, 60% are controlled by us, by the car that we buy, by the house that we rent or build, by the way we eat, by the way we consume. And that is very often forgotten. And so it is also winning the hearts of people. And the health argument couldn't be a better one to do that. These are the 4 things we have the power, the lever, to reduce the footprint of ourselves. This was a study where we proved that invoking the health benefits does change the household members' preferences to go for a climate healthier lifestyle. You can look it up in this project website. Okay, and here is the paper, and it shows that, see in the red, our study is the first to show that providing health information on strictly unconditional individual health co-benefits can motivate households in high-income countries to adopt mitigation actions, one of these 4 areas. So it works. What's good for the climate is good for health in many cases, if not most. Now we go to the red part, the strong health damage. And I could give you now a rundown on 110 diseases, but I want to save your energy for the rest of the day. It is a whole lecture series of a week, but just an overview. Yeah, of course, you know this. This is from the Lancet Commission, 2015, Watts et al. And it gives a nice overview. You have here the greenhouse gases, and here you have the components of climate change. The oceans get more acid, higher and warmer. There is altered rainfall patterns, which we said, sea level rise, which we said, extreme weather, which we mentioned, raised average and extreme temperatures, and other air pollutants, like ozone, particles, right? And they go through all sorts of pathways, very often merging their causal effects on, let's say, undernutrition. There are at least 4 arrows that come from somewhere here. So you can go through this in peace and quiet. But also, this is not happening like in a laboratory. You have the entire social determinants of health here. You have other ecological. So it's a very, very complicated thing. And to do research in this area requires really the best of all disciplines to work together. Let's zoom into just one thing, which is malnutrition. And this is the additional number of undernourished children below 5 years, which is to be expected in the business as usual scenario. And in sub-Saharan Africa, this is 10, about half of 25 million altogether. So we have 25 million. That's an estimate, but it's based on very thorough modeling. And this is something that is just mind-boggling. Here's another piece of our research. We try to go with the London School, with African research centers, and with Christoph Borner from the climate science, my friend Paul Wilkinson from the London School, and we looked at downsized on one population in Africa, one district, one health district. We downsized climate models. We developed weather crop models, and now we try to get into crop yield mortality models, and we could show that the number of kids that were dying because of changes in the food yields of their fields, because they largely eat what they grow. Of course, there are other factors, market prices. Peter will tell me more about this. It's very complicated, but in those societies, if there's a bad harvest, that means there's malnutrition. And here's just one fascinating thing that we just published. You can see one village here, and these are the fields, and we can estimate or quantify from a satellite what the harvest of the farmer is. So here you have sorghum, and you see this is 3 tons on this field, 100 kilograms of millet here, and so forth. So we monitor the households of which we know the nutritional status of the kids in terms of their agricultural yields, and that we compared to the vagaries of weather as driven, among other things, by climate change. So we try to get a picture from all angles on the development of undernutrition as a consequence of climate change. Just looking at, I don't want to talk only about Africa, although I work most of the time there. This is what I prepared for an audience of German physicians. And I just put /Canada there because I want to challenge you whether this is not very similar in your case. We have, yes, we are rich. Yes, we have a good health system. Yes, everybody has access to health. But we have very vulnerable population. Lots of elderly. We see this in COVID. Of the young, we have a lot of comorbidities, also revealed by COVID. Diabetes, hypertension, mental, all this is worse. Renal disease, outdoor workers, we do a lot, and the poor. So it's not as if we are safe. The largest impacts are heat stress, diabetes, can't get into the details, cardiovascular respiratory diseases from air pollution, allergies and asthma, kidney stones and renal injury. You can ask me about it if you like, how this is working and how diabetes is influenced by climate change and heat, and infectious diseases. And then there's a long list of infectious diseases that also hits us, notably, of course, Candida, borreliosis, and tick-borne encephalitis, hantavirus, nephropathy, and so forth. Now we go to the health sector.
5 minutes left.
Yeah, thank you, Matilda. Health sector is a big emitter, so we should be self-critical here. I would, if this was a direct in-person presentation, I would ask you, the global footprint of air travel is 2.9% of total global emissions. How much do you think is the footprint of the health sector in Canada? Write it down. Here it comes. So all in all, it's 4.4% of the globe. That includes Malawi and Papua New Guinea. So the globe has already more from health sector in terms of emissions than the air travel sector. Canada is 4.6. I'm surprised. Germany is pretty bad. The US, of course, and Australia are always in the upper range of emissions. So Germany has 6.7%. When I tell this to health folks, they fall off the chair. They always thought that air travel is the main problem in Germany or worldwide, but it's not. Okay, but there are countries like the UK with their national health service, and I think Canada could do the same. I didn't have the time to check whether you do. Maybe you can tell me later. That really have emission targets for the health sector. So they want to reduce the CO2 emissions by 2050 by 80%. Every good company, every good household should have that. Every good country should have that. And they are on the right path. They have already reduced since 2007. They have already reduced 17%. That's good, but not yet there. But at least they have a target, and they try to do it. Limits of adaptation, I mentioned that in my MOOC. I don't want to go into detail. I just want to let you know that you can look at adaptation as a good thing. Yeah, the health sector can go a long way if well designed to protect populations. That's the green part on the left side. And on the right side, don't think we can handle this if you let the climate run wild. There's no way. Nobody can claim. So it's a good and bad news, if you like. Adaptation measures, a quick rundown. It's pretty obvious. One could drill in each of these points. The main thing is good health systems. That's true for COVID. That's true for Ebola. That's true for climate change. That's true for everything. If you leave health systems rot or be inequitable, accessible, like, for example, in your southern neighbor, that is just bad for all kind of health threats. The health-relevant public goods, that's also good for everything. But then there are specific things. Surveillance and early warning system for nutrition, for bad harvest, for vectors moving in, and for climate-sensitive illnesses. Climate-sensitive intervention, what do I mean? For example, if you know that under climate change, the micronutrient content of corn, for example, changes, gets worse, then you can teach, which is done in Bangladesh by a colleague of mine, teach women to have home gardens that grow particular local foods that are rich in zinc and rich in iron and rich in protein. You know? So that is a specific intervention counteracting a deficit from climate change. Risk-sharing strategies here, Peter will be interested to hear that. For example, insurance. I came from health insurance and did a lot of work on health insurance in Africa and India. And now it's weather-based crop insurance. That is tested, that is the first experiences are in. Can we connect climate warning, and weather surveillance with harvest surveillance and crop insurance? So risk-sharing strategies are, of course, good for anything that hits as unevenly as climate change. Communicate to the to the policymakers that we can't help you once it's out of control. And this is something which takes a lot of time. Just have a look at it in your quiet, maybe later. The basic message is, you see here from the upper left to the big circle, it is the stress of climate damage in all these sectors of the circle, from undernutrition on the top to air quality. And you see the various possibilities of adaptation. And the yellow part is cannot adapt away. This is the residual impact in the best of health systems like Canada or maybe Sweden. So there is this space that you don't get rid of if you have 4 degrees. Already today, this is the present, in extreme weather events, we cannot prevent very bad monsoons hitting or hurricanes hitting Puerto Rico. And there's a lot of health damage. So that is already happening today. This is happening at 1.5 degrees. All the sectors have already, although it's a smaller proportion, of non-adaptable residual health damage. And this is, of course, out of control, as I said. Now, the last thing, the last but one thing I should say, is health-mediated economic losses. Just quickly, just this one slide, if you're interested to dig deeper. There is a law that from physiology, which the ILO, the labor organization, has figured out. Here's the temperature, and here is what you can do. This is cutting wood in Canada, 500 watts. This is maybe office work that I'm doing now. And this is as the temperature goes to 27, the wood cutter has only 70% of his capacity. So it's an inexorable loss of possibility to perform, even in office jobs. So this means that in those countries where you have a lot of excess heat, you have a lot of loss of productivity in outdoor work. And now health science, and then I come to the end, Matilda. So no more red cards like in soccer. I understand that this is necessary. So health science, this I'm talking at a university, for a university audience. What can we contribute? The short answer is evidence, but this is not as easy as it seems. Look at, first of all, how do we do compared to transport, industry, economy, the energy, research. And this is the number of publications in the 10 years preceding the Paris conference, and this is health. So bad. Half of what the transport sector produces in papers. So there's catching up to do. And here we look at Medline citations. You have air pollution, tobacco, obesity, all very important risk factors, but climate change is absolutely underdeveloped, given the threat, particularly on older people and on future generations. So the current state is not good. It's getting better. After Paris, there was a lot of catch-up, particularly with the Lancet Commission, and this is there's good news. But this is a snapshot of 2010 2005 to 2015, it has improved, but it's not yet there. Now, just one project, not to sort of self-congratulate. This is a project we just acquired. And you see, it's 9 universities. Nobody can do this on themselves. You need agricultural people, you need malaria specialists, you need climate specialists, you need partners from Africa. There are 2 here. These 2 are from Kenya and from Burkina Faso. You need nutritional specialists, you need economists, you need modelers. So it only works, which is true in public health, in principle anyways, but more so in climate change and health, where you have to join strange bedfellows like meteorologists. Never worked with a meteorologist before, but now I am. So we need to be innovative and be good at managing consortia. And here's our concept for this one. We pick 4 main climate impacts of sub-Saharan Africa: undernutrition, heat stress, malaria, and malaria 3, and policies are cross-cutting at the bottom. And then we look at impacts, at adaptation measures. These are intervention trials. And then we project what we find in 6 years. We get the exposure response functions, and we incorporate these in climate models, and we downsize for this little 25 by 25 kilometers area. And we can predict something for a real population, which is so much lacking. It's all about country level or so. So this is one possibility, and there are population cohorts, there are community randomized controlled trials, there are impact models. So this is the way to go. In a similar fashion, combine large teams of good scientists of many fields and get a good concept, focus on some diseases, and make sure you also do adaptation. Of all these papers that were published in this 10 years before Paris, only 5% were about adaptation. It's more complicated. So what shall we, academia, do? Truly transdisciplinary research centers, I understand you are one. So where's your climate partners? Where are your meteorologists? Where's the Department of Agriculture? Of course, some of these you have already contacted, but you want to maybe reach out to the geological and earth sciences, not geographical. Then we need to teach our young and ourselves how to do this. And so there are new methods to learn, which I had never heard before. Yeah, and climate modeling and so forth. We can use MOOCs. I'm a very fan of MOOCs to quickly disseminate this knowledge. And we need to engage to change policy, because without better climate policy, everything we do as health folks is in vain. Conclusions. There are 8 roles of health in climate change, the positive and the not so positive. The positive ones are, it's a motivator. It generates good health. And why do you do something for the climate? We can generate evidence. There are tricks, because it's such a long thing about climate change and what can you do in 3 years? Well, there are tricks to do that. It protects population, it's a protector, but it's also a victim. Health is affected by climate change. We are perpetrators. The health sector generates emissions. It generates economic productivity losses, and there are definitely limits to adaptation. So this is the key of the health argument. I've stated this several times. And then the huge catch-up needed in health from climate science. And I mentioned how this could look like. And this is the end. And if you see these 4 clients up there, these were the ones on that graph, which I showed as one of the initial graphs, where my doctoral student from Africa says, this is me, this is my dad, and these are maybe the next generations which are going to live through whatever we put in the atmosphere in our lifetimes. Thank you very much.